like that. Now, so you know, now if you turn, you should turn to activities of daily living, the very next page, and I want to put some goodies on the sheet. This is just a sheet that you can take a bunch of freaking notes on and just throw them in there anywhere you want. Make sure you know advanced directives. Make it your business while your patient is with the program to discuss it every chance you get. But remember what I taught you? You're supposed to make it fun. Stop making it so damn serious before they think you want their will, the money in their will. I mean, you want to know who's getting a bicycle or something. You got to kind of make it a little bit more fun. You got to have your patient and their family member there, and they're getting admitted, and once they're all settled in and things are, stable, maybe even the next day or something. Now listen, guys, have you thought about your will, or not your, I don't say will. Have you thought about advanced directives? It's been my experience that most people are not really clear what that is, and that's true. I don't know what the fuck you're talking about. And so you just make a point of saying, as you go through this hospitalization, this one is no big deal. We're going to get your mom together. Everything's going to be pretty good the way it's looking. But you probably should start talking in a real kind of gentle, loving, kind of maybe even a sense of humor way about who you want to make decisions for you. Who is it? Do you have that one kid that you know will always make those decisions the way you want the decisions made? Most of us sitting here today have a couple kids. If you don't, God bless you. Start thinking, I am blessed. I can do my NCLEX 4000 homework without any interference whatsoever. But for those of the rest of us, which is 99% of us, who have the little ones, I have grown-up girls and grown-up boys. And I already know who it is, even now, that I probably would say needs to make the medical decisions. That one is just all about the game, right? She's like, okay, we're going to cross the T, dot the I, read the small print, make sure you don't sign up stupid. That daughter, right? You all have at least one. And then the other one is mommy's little marshmallow. If I'm going to be a crybaby, I call her. If I want sympathy, I call her. If I want her hug from the phone in Ohio State, I call her. If I want something to get done right, no bullshit, I call the other one. You just know your kids. So make sure you know, when you talk, my girls have heard me say this repeatedly, that okay, you're going to be the little medical person that makes my decisions, and you're going to be at my side making sure I'm warm and cozy and my music is on. Deal? That's how much fun you should try to have with this. It should not be this like, why is she talking to me about advanced directives? She think I'm going to die? Talk to them just like I'm talking to you. You all got them kids. You know which one going to do what. You already know. Okay, so do it like that, because then you're not looked at suspiciously. Does she see something in the chart that I don't know? Does she think mama has cancer? No, it's none of that. Just start playing with it a little bit. Be a little bit more loosey-goosey. I don't think we do justice on this topic, because do you have any advanced directives? Who's your medical proxy? What? What does your patient say? No. Almost 90% still say no. That's a problem. We are getting very far with this conversation. We call ourselves passing a law 10 years ago. So why 90% of the people still saying no? Because we didn't get anywhere, okay? So Alzheimer's and activities of daily living, we're on this one, but Alzheimer's patients better have advanced directives. Because if we can catch them in a mild state, they still have rights, right? And they can still make really good decisions in the mild phases. So put that on your little ADL. Make sure your Alzheimer's patient has advanced directives. Because you will catch them at times where they can still make decisions, and they do very well with it. Okay? And by the way, just because you name somebody to be your healthcare proxy does not mean they are until you can't speak anymore. So it's not like they're going to suddenly take over all your shit. No, they only come into play when you can't talk to me anymore. Please remember that. They don't boss you around and tell you what they want. You are who I'm going to listen to. until you can no longer tell me what you want. Okay, because I think people get confused about a medical proxy. They'd be like, she gonna be telling them everything. No, you still gonna tell me everything. Okay, hospice, what do we say about that? Certification with what? How many months?
6 months.
6 months life expectancy. Okay, the most important time to make sure you remember hospice is when the patient can no longer talk or walk. When the patient can no longer talk or walk, and they keep having recurrent complications like pneumonia, falls, bladder infections, pressure injuries, weight loss, muscle wasting. Okay? Every elderly patient would benefit from a multivitamin and a liquid supplement like Boost or Ensure as they get older. Checking the dentures to make sure they still fit. So when we look at nutritional issues, the dentures are a big one. Again, we're dealing with people who got dentures at 50 or 60. They're 90 and they don't fit. Small, frequent meals. Chew food thoroughly. No such thing as eating too fast at this point. You don't want them eating fast. Daily weights should be implemented for most elderly patients. Daily weights. Okay? Next page. This fluid volume deficit, which you know is the fancy language for dehydration, is kind of nice because this patient's at such a frequent, constant risk of being dehydrated. Make sure you know the earliest sign of dehydration is a dry mouth. And when you see it says increased thirst on your handout, I'm going in order, make sure you know they don't have a thirst reflex. So they have a decreased thirst reflex where it says increased thirst. That's for you and me, but for them, they have a decreased thirst reflex, so they're not going to be that thirsty, yet they need to drink. Definitely in the elderly, confusion is a sign of dehydration. Everybody see that? We're going in order. Oliguria is on your sheet. That makes sense. Where it says decreased weight, how would you know unless you made sure your patient understood daily weights were important? Daily weights. That's why we tell you, get in the habit of teaching daily weights. Asking about a scale, just like we do with new moms and car seats. Where it says dry skin and skin tenting on the right-hand side, remember we check the sternum of our patient for skin turgor, because every part of their skin is thin. So if we check the sternum or the forehead, both you have to know. The sternum or the forehead for skin turgor, you will be checking for tenting, right? Pinch and try to pinch a little bit and see what you got. Cap refill is actually greater than 4 seconds with this patient. What's the quality of the pulse over there where it says heart rate? What's the quality of it? Let me check it. Weak and thready, poor veins for your IV, right? So weak and thready, flat neck veins, all that good stuff. Postural hypotension. You already know that. What's CVP stand for?
Central venous pressure.
Central venous pressure. Remember, fluid is always a venous issue, not arterial. It's always a venous issue. Look at the box. You already know those labs are important. You know those labs are important. So you see where it says increased urine-specific gravity, put your dark urine. Where it says increased RBCs and hematocrit and hemoglobin, wouldn't you agree that the blood is thick? Thick blood has what? Osmolarity. So increase OSM. Increase OSM, osmolarity, greater than 300. Increase osmolarity. OSM greater than 300. Cool. Okay, turn the page. Not a whole lot on this page other than remembering that under hot flashes, I want you to remember they may interfere with sleep or menopause. And because they interfere with sleep, patient may be moody, have a little bit more anxiety. Under atrophy of vagina, just put dyspareunia. Here we go. And Lord only knows if I'm spelling this right, so screw you guys, right? Better look it up. Dyspareunia, I kind of joke with you, and we call it a dry, pruny coochie. Lord help you. So put that under atrophy of vagina. Dry, pruny coochie, vaginal dryness, water-soluble lubricant. Okay, so you see that. Osteoporosis, make sure you know, is actually pretty rare in the African American. And you don't get this, you don't always get your doctor that's familiar with culture. So we still have a lot of doctors writing for osteoporosis medications in the African American female, and it just is ridiculous, okay? So Asian and Caucasian are higher risk. The African American is at risk if they're on prolonged steroid use. Just remember that steroid use will decrease your bone density. But typically Caucasian and Asian patients are at higher risk. Teeny tiny, skinny, mini little ladies, right? That's why we said in elderly patients, we prefer you to be a BMI greater than 25. We don't want your ass up at 40, but we want you to have a little bit more weight on your carriage, on your body. We don't want you to be less than 25. We want you to have a little bit more weight on you. Okay, it's actually a good thing. To all us fluffy people feeling good about our sickos. Yeah, I'm keeping waters. Stomach. Our fluffy's good. All right, I'm not 60 yet, I guess not. But coronary artery disease. This is a very high risk for a heart attack in a female. Once they hit menopause, they're at very high risk for a heart attack. They, on average, are going to gain 15 pounds in menopause. And it's all going to be around their midsection. Sucks to be us. Okay, so midlife weight gain on average is 15 pounds. Estrogen is gone down, and that's what used to decide where your weight went. It used to go to your boobs, now your boobs are on your kneecaps. And you dropped all that nice dense boobs to your knees, and you're done. That's all it is, y'all, that's simple. Okay, now turn the page. Oh, you should probably have osteoporosis or some shit. Yeah, okay, so if you look at this lady who has a bunch of deformities, one is called kyphosis, dorsal kyphosis. The other one is cervical lordosis. I need you to remember the lordosis patient as lard ass. That's how you're gonna remember it. Okay, so lordosis has a lard ass. LL. And that's how you're gonna remember who has a big ass. Pray about it. All right, now, big old booty and big old neck. That's what the cervical is for, the neck. Okay, dorsal, back, hunchback, Notre Dame, right? It's the hunchback. They look very different in terms of their stature. Now, what do we gotta do for this lady? Well, you already know how this goes. We gotta stop all that damn drinking. Drinking is associated with osteoporosis, and most people don't know it. So no. You gotta put no more than 3 drinks a week, if that. Drinking is associated with osteoporosis. Weight-bearing exercises would be good here. We tell our patients to get into a dance class. That's why there's a lot of dance classes popping up. So get into a dance class, dancing, walking, treadmill, elliptical, all of those are weight-bearing exercises. But dancing is way more fun, all right? Calcium and vitamin D supplements, falls precautions, flat shoes. Keep in mind, it says this on the page already, just highlight it. If you highlight over on the right-hand side, hip fractures and CHELLYS fractures. The CHELLYS is your wrist. That's dual wrist fracture, so both your wrists are broken with this osteoporosis. The other side says slender female Caucasian. You need to put Asian right by that word. Slender female Caucasian, add Asian. Look how it says alcohol, y'all. Alcohol users is higher risk than smoking. And then remember the steroids. And then I need you to put Depo-Provera, add a medication. Depo-Provera. So you can't use that more than a few years. It's a great birth control, but you don't want to be on it forever if you're at risk for osteoporosis. And then remember also to put Dilantin. And what I tell you about Dilantin and Depo for osteoporosis, she loves the D, right? So for Dilantin decreases vitamin D. D for Depo, D for Dilantin, for decreasing vitamin D or calcium or bone density. D for decreased density. All right, y'all, DEXA. D is also for DEXA. She loves the D. So if you turn, you'll see a DEXA scan. Bone densitometry, DEXA scan, vitamin D, Dilantin, Depo. She loves the D. Now, remember to put on here, the only thing you need to put on here is that this screening is done at 65. That's all you need to know about that, except I want you to go down to the bottom on the T-score. Highlight the word T-score at the very, very, very bottom. T, tiny sign in a square. And then highlight the very last word, which says less than negative 2.5 standard deviations. Everybody see that? Yes. Okay, that's important. Page. So you have this page that says JAMCO, and this page and the one after it is trying to get you, the nurse, to make sure before you think someone has dementia that you actually make sure they don't have delirium instead. So this JAMCO page, it talks about the meaning of judgment, affect, memory, cognition, and orientation. And what I want you to write on the top that you've heard me bitch about constantly is that you are never going to give antipsychotics to this patient. No Haldol, no Seroquel, no Abilify, none of this nonsense that you see. There's a New York Times article about it. There was Mayo Clinic doing a talk about it. It is just outrageous to be giving antipsychotic medications to these patients, and you know that that's true. I always tell you to remember that we didn't even have those drugs. Remember, the atypicals are new. We didn't even have those drugs when I came out of nursing school. So the fact that we're throwing them at the elderly like we don't give a shit is crazy to me. Now, you do have to write why. Does anybody remember why we're never going to give Seroquel, Abilify, and all those other antipsychotics to this patient? Prolonged QT interval. Prolonged QT interval. It is a black box warning right on the freaking drugs that you're giving. Black box warning. Prolonged QT interval. Leads to dysrhythmia, stroke, and MI. Insanity. So what should we do? Let's make a little select all list of what the hell we can do. We can get a sitter, or actually, buy a sitter for this patient. We can have them hang out with us at the nurse's station. We can get them a doll or a busy blanket. It's called a busy blanket. We can give them a doll to take care of or a busy blanket. We can call the family. Don't ever forget that option. Call the family in. It helps all the time if they're in Cleveland with the family, right? So if they're here. Make sure they have a big face clock to help with their orientation. And a calendar with big numbers on it. Decrease stimuli. So quiet, calm environment, decreased stimuli. Frequent reassurance of where they are, what day it is, what time it is, what's happening next, like dinner or whatever. Touch will comfort the patient. Remember, touch is the most powerful form of communication, and many of you were taught in school not to touch, which is scandalous. So you are expected to know that touch is the most powerful form of communication. And these patients need touch. They need different things that will help relax them, aromatherapy, the little dog that they have in some of these facilities, the pet. Some people have already got a dog, realizing that these patients love this dog. That has helped, believe it or not. Soft, warm clothes and towels and blankets at bath time. Remember that? Soft, warm, thirsty towels, they call it in the advertisement. Those things actually work. Okay, at bath time. But to give Giodon and Haldol and the Bill 5 Servo is absolutely absurd. Okay? All right. The next page. Please highlight the word doesn't, because that's the most important word in that sentence. It says dementia. Make sure the client doesn't have any problems with da 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 da, right? So drugs and alcohol, this is, maybe your patient is acting out the way they are because some nut gave them an antipsychotic, or somebody gave them double the medication, or someone, oh, let's do my favorite. I had one of my beloved nurses went on vacation, came back, patient's acting all crazy. And it was her patient, so she's like, what kind of games is this? What is going on here? These losers that had been taking over on her patient while she was on vacation, I think she got married for 2 weeks. They had 5 XLR patches on her. So what's going on with that? And a lot of you have told me you see that quite often. What's going on with that? Falsification of records, fraud. Oh, I'm sorry, fraud on the Medicare patient, which makes it a great felony. Because what did you sign when you put the patch on? That you removed the last one. That you checked for any others. Yeah, you signed that. Don't forget what you're signing. When you sign that you put a new one on, you're signing that you took the old ones off. And because you didn't, if for any reason that patient had to go to the real hospital other than the long-term care, like for a complication, and those nurses caught that crap, you'd be seeing state in your doors. And you should. So hospitals report nursing homes all the time. Because they're just so sick of the horrible negligence and the abuse that goes on in some of these facilities. So please, I just was mortified when she came and told the class, and I asked the whole class, have you ever seen that? And they all raised their hand. They're like, oh yeah, we see patches on the patient all the time, 2, 3, 4 patches. What? That is so scary, because don't each patch have medicine in it? So now you give her an overdose every day. No wonder she's loopy. Okay, and that's what she said, her patient was loopy, like so not normal. And that's what they did, they kept leaving the patches on them. Scandalous. okay? So, might be that deal. Eyes and ears, maybe you think that they're having dementia, but really, they just don't hear you, and you talk like this. Okay, so metabolic and endocrine disorders. What endocrine disorder could make your patient confused? Specifically, what could be wrong with them in endocrine?
Diabetes.
What in diabetes?
If they have hypoglycemia.
Hey, go get it, girl. Hypoglycemia, right? What endocrine disorder that's more chronic, other than diabetes, could also do it? Addison's, absolutely. Good job, y'all. Emotional disorders, maybe they're just depressed, okay? So what do you know about depression? They ain't getting out of bed. They're not trying to hear nothing you're talking about. Neurological disorders, well, I had one of you little love bugs who really cares come back to work and notice that the patient was just not right. And here he had fallen and bumped his head the day earlier. And when you found out about it, it was because he told you. He had a brief moment of lucidity, at which point he told you, they ain't tell you I fell real bad yesterday. And you're like, no, you fell, and you couldn't find it anywhere in the nurse's notes. And you didn't get it in report either. So you, of course, being of sound mind, body, and spirit, decided to send him out. Good thing. It was a subdural hematoma. So maybe your patient fell and, they just forgot to tell you. The shit I see is ridiculous. Tumors, that would be, I don't know if you recall, one of my favorite people, John McCain. The week he found out he had brain cancer, he was loopy as hell in one of the hearings that he was doing. Just weird comments and loopy. And it turned out he had brain cancer. So yeah, could be a tumor, could be brain cancer. Okay, you're just not quite saying the things you're supposed to say at the times you're supposed to say them, and you're blurting out weirdness, and it didn't make any sense. He was talking about like baseball in the middle of his hearing for some senator. It was just weird. Like, oh my God, now it makes more sense. That was his brain tumor. Okay, because that's what it's going to do. It's going to make you totally not make sense at all. Infection, you know how this goes, UTI. I would add dehydration or electrolyte imbalance. And then I want you to make sure you see arterial vascular and then add nutrition. A really bad malnourished person won't make any sense either. I'm sure you can imagine. Okay. Now I do want you to remember, because you may not know this, that 1/3 of all hospital admissions will have delirium. Delirium is reversible. How many of you have heard ICU psychosis? That's delirium. It's temporary, it's reversible. Who remembers the Saturday Night Live guy that had a horrifying tour bus accident, and he came on TV and said, I'll never forget my nurses. And he said he wanted to go visit the nurses that took care of him. He was sometimes posted from time to time, Tracy, I forget his last name, but he's hilarious. But he had a very bad tragic accident, he was in a coma for God knows how long. And he said, when he was talking, he was trying to, kind of bring it on back. I just really want to thank my nurses. They put up with me. I was a hot mess. I could hear everything they were saying. They were so kind. They would hold my hand, and I'll never forget them. That's why I'm here, because a lawyer that was sitting with him on the Today Show was saying, we just want to thank the doctors for bringing them back to life, and thank the hospital for the care they gave. No, I want to thank my nurses. I just want to make sure they hear me out here. Y'all are the bomb. And he's like, I was going to visit the one because I know I was so mean. And they didn't even care. They were so loving. They reached out and hugged me. It was the most powerful example of how patients remember everything you do. And he said, I was delirious. I didn't know where, I didn't know what. I was throwing things and fighting. And I just felt so bad because I felt like I was out of my body. Delirium. They have delirium. Anemias can be so bad. And fevers make it worse. Okay? Fevers and those alarms. Those freaking buzzers in your ear all day. Those ventilator alarms and shit. That's gonna make anybody crazy. Out of your body or some shit. Okay, so you get it. Okay? Now, if you look at sundowning, where does this come from? In terms of when you really see it. Because when you see the picture on here, it's kind of like what happens, but not. So what happened to our patient, y'all, by the time 3 in the evening or 4 in the evening rolls around? We're going to turn into a werewolf. Y'all see the little picture? Okay, so what I want you to do is I want you to color the sun in the very first picture, real bright yellow, orange, something like that. And then the window in the last picture, color maybe like a light bluish kind of something like that. See, because it does not happen in the middle of the night. That is the misconception. Sundowning starts around 3, somewhere around change of shift. Starts around 3 p.m. and right around 3 p.m., 4 p.m., shit hits the fan. Your patient have packed a bag, they about to go, they'll tell you they're going to work, they'll stand by the elevator, wait on it to open, they got their flip-flops on or slippers on and they're going to work, okay? Because that's what they did for 50 years. I know you can't appreciate it, but people used to work the same damn job for 50 years. They got that big old watch at the end of retirement, that big cake. It's just what people did. And now we have an average, and this is what sucks. We have an average of 20 jobs before we die, if you are working right now. But our baby boomers, they worked one job for 50 years. And so when you do that every single day, you're in that rut. Let's go. Now, what causes sundowning? Lack of natural light. So it's almost like a crime shame if you have a patient institutionalized with no windows. If you don't roll their wheelchair outside in the beautiful sunlight, it's a shame. I did remember that about Wycliffe Country Place Nursing Home, which is where I got my first little nursing assistant job. They would put the patients right outside on this really pretty little area, and the patients loved it. And they need that natural light in order to make difference of night and day, not to get confused. Now, it's more common, of course, with Alzheimer's, right? So sundowning goes as part of Alzheimer's, and they just become very confused. And they try to leave or go catch the bus or go to work or meet their daughter. Sometimes they're looking for someone. I'm going to find my husband, or we're going on vacation, or whatever it is. But they're packed up and ready to go. And if you're not careful, they'll have that little gown on with their ass flapping in the back, ready to go. Okay? Now, if you don't have some sort of, lock unit or something where they can't go, they can go. And when they do, they end up at car sales people. I remember getting a call from, I think it was Lally Chevrolet. Hey, we got one of yours over here. Now, we had a ID bracelet on this guy, so they were able to figure out where he was from. Think about all the assisted living organizations that you know or have worked for. They don't put ID bracelets on their patients. Let me tell you how jacked up that is, and hopefully you'll change it. Because one thing's for sure, assisted living patients are anything but assisted living. They are generally patients who need a lot of help, more so than you ever knew. And there's a few residents who don't need much, but the majority of them, remember what they're doing with these facilities. You gotta remember that assisted living facilities are not regulated for a quota of nurses or anything, which is different from a nursing home. So they're not regulated at all. And so the patient has moved into this residential type of setting, and when they do get older as the years go and develop some dementia or Alzheimer's, they don't have to leave. So you're dealing with extremely sick people, sometimes with regards to their memory. When they leave, let me give an example. There was an assisted living organization here in Ohio. The patient eloped, right? That's what we call it, you better know that. The patient left or eloped, and when they left, they got hit by a car, broke their shoulder, fractured their shoulder, went to the hospital as Jane Doe and completely out of it, and no one knew who she was for a long while because she didn't have an ID bracelet on. This is what you're dealing with. Jane Doe, we were Jane Doe up here with a fractured clavicle and scapula. Got hit by a car, left out there in the rain up there in Bedford. Out there on that auto mile, that long shirt, was that Rockside or Northfield? No, Rockside, that auto mile. She got hit up there. No one knew who she was. Sundowning, she left. I thank God that Chevrolet called us and said, got one of yours. Because he was up there with his ass flapping in the wind with that naked gown on trying to buy a car and get the fuck out of here. I ain't mad at him, he's trying to go. I ain't mad. But you gotta remember, this is real. This is real. Who's seen it? You guys seen Sundowning? Where'd they go? What are they trying to do?
Well, she was on a lockdown, so she couldn't actually leave, but she would be adamant about it, like, almost like upset, want to fight.
Oh, yeah.
Yeah, and she would do it like every day.
Every
Like, if you
single
knew
day.
what it was, and it's to the point where just let her go. Because it was more frustrating to her. Like,
Yeah,
why
don't
would
do
you
nothing with her.
We just let her do it. Oh, yeah, she about to get ready to pack up. You hear her in there. And she's folding everything up, tying it in bags, and rolling it with the wheelchair, and will sit at the elevator waiting for it to open
Just
up.
waiting. It is impressive because they're very serious about what they're doing.
Very serious.
Yeah, every day, every single day. So here's what you do. Select all. Melatonin really helps. Natural light is critical. No caffeine after noon or at all. And they always get coffee with dinner, just impressive. So no caffeine for these patients. No sleeping pills, that accentuates it big time. No naps more than 30 minutes in the early part of the day. No naps more than 30 minutes. So if they take a nap, 30 minutes later, they gotta be up and at it. Exercise before 6 p.m. Check medication administration times and their bedtime ritual. So you need a bedtime ritual or routine. But the most important thing we can do for this patient is expose them to natural sunlight. And then let the unit get darker as the evening wears on. Okay. Okay, now, so we have Alzheimer's, right? So if you turn, you should have 5 A's of Alzheimer's. I always add more A's. So of course, if I've got 9 A's up here, I'm adding at least 4 more. And what I want you to do is I want you to put an A for Aricept. You do have a handout for this, you don't have to turn because I'm just mentioning it. Because this is the #1 medication, Aricept. We give this out like M&Ms. In other words, you don't need any crazy formal testing. You just need pretty convincing information from family and patient that this might improve their memory. This may improve the ability to do activities of daily living. It is very common. Most of you have given it out as a student. And again, it's for Alzheimer's, but remember, Alzheimer's is only able to be diagnosed on autopsy. You can't really technically diagnose it, you can only work it up, because it's only really diagnosed on autopsy. Okay, that's why a lot of the guys that play football dedicate their brains after they die, so they can have an evaluation of it. since they have similar symptoms. Okay, so you have your Aricept. You also want to add the A for amyloid plaques. Amyloid plaques are basically sticky plaques of almost like cholesterol or something in the brain. So we call it tangles, plaques and tangles. Remember that? That's what we're going to see on MRI. Plaques and tangles. And so when the patient gets a workup, you're going to see these amyloid plaques in the brain. The problem is we've seen amyloid plaques in people's brains that weren't Alzheimer's. But typically there's no Alzheimer's without amyloid plaques. So we could say that almost every single Alzheimer's patient will have amyloid plaques, but not all amyloid plaques will become Alzheimer's. That's why we say it's not diagnostic. Okay? All right, then we know we're going to have an issue with acetylcholine. So the medications that we give this patient are going to work on this acetylcholine. Okay. So Exelon is directly working on decreasing the acetylcholine. The last A is Amyvid, which is the testing that we do with a PET scan. Amyvid is new in the last 5 years. We have a dye that we use now, and we use this Amyvid, which means video of amyloid plaques, video under PET scan. Remember with the PET scan, we give you sugar-based dye. And this patient with amyloid plaques, the amyloid plaques suck up the sugar-based dye. So it's called Amyvideo or Amyvid. It's a radioactive tracer that we use. Okay. Now you can read, just like I can, the different things on your page, so you kind of know roughly what this is. And we're going into much greater detail in the actual lecture setting. But what's important for you to know is the stages of Alzheimer's. Those are very, very, very important for you to know. So in mild Alzheimer's, and that's how I would separate it. I would say mild or early, moderate, and then I would say severe or late. Use both terms. So early or early or, what did I say, mild? Okay, so if you think of mild Alzheimer's, this patient is frustrated whenever they have to learn new things. They're frustrated whenever they have to learn new things. It begins 15, 20 years earlier, generally decades earlier. Half of all patients over age 85 will have Alzheimer's. Half of all patients after age 85 will have Alzheimer's. It's the 6th leading cause of death in America. It is the #1 reason for bankruptcy because it's financially depleting of all your resources. It kills more than breast cancer and prostate cancer combined. The mild form has memory lapses of recent conversations, events, and appointments. Memory lapses of recent conversations, events, or appointments. An inability to make decisions and becoming overwhelmed when you're told to do so. An inability to make decisions and becoming overwhelmed. So Papa used to say, what do you think, Barb? And he's never delegated in his life. He's a patriarchal guy. He's in charge, H&IC. And he started doing this whole, what do you think, Barb? She said, what do you mean, what do I think? And it threw her off a little bit because she always looked up to him to make the decisions. Well, I just want to know what he thought. Oh, well, I guess I think that we could go and do it. Okay, so she kind of had to jump into that role, and they are very traditional in my family. The woman does the kids, stays home, cook, and the guy's provider, protector, and the he-man, the hero. And that was weird. What do you think, Barb? Oh, I don't know. Okay, so she was trying to hear that. Like, look, Bill, you know, make the decisions. Okay, so it was a little weird to see that, but that's what they're going to do. They're going to be overwhelmed if you make them make the decision. Okay, make sure you know depression. They're not stupid. This patient knows that they are not quite right, and it is driving them crazy and subsequently causing depression because something just ain't right. It's very sad to see a realization that this is not going the way they wanted to go. Asking the same thing every day, all day, like, what day is it? What day is it? What day is it again? Say which that day was. And this is like 5 minutes apart. That's how repeated questions are. So finally I laughed. My sister, she puts this big sign on the kitchen table. Today is blah, blah, blah. She didn't care. Then, honey, what day is it?
Still mild.
Oh yeah, this is very mild. Yeah, this is very mild. Because in a minute they don't care what day it is. It's like, good, one day is into the next, right? So this is all still mild. Mild is huge. Because what I say, 20 years. 20 years it's going to take for you to kind of figure out something right here. Okay? So repeating themselves over and over again. So the girls used to say, watch, he's going to say, this is really, really good every time we give dinner. Like I bring dinner over. This is really, really good. Then one day he said to Mama, and her feelings were so hurt she cried for days. I waited all these hours for this shit. He's always said this is really, really good. So she was so hurt. I said, Mom, no. He had chemo and radiation. He does not taste your food anymore. Oh, well, he didn't have to hurt me like that. I've always cooked for him. Oh, so sad. So you want to remember that the family is looking at this going, okay, yeah, I can appreciate this is an illness, but it hurt my feelings. Remember that. It still hurts because you're human. Okay, that we all get it. This is not him, but it still hurts. So you got to remember that on these issues in the mild stage. Because when it's mild, you're like, you know better than to say something like that to me on your life. Okay, which is what she said. Okay, misplacing items, getting lost. So we got that first call. I don't know where he went. He got in the truck and just left. And he ain't been back since. I'm like, for real? He was lost. Lost. Got a little lost there. And it was the first time, so we were like, oh no, this is not good. So what does that mean? He probably is not going to be able to drive, right? So that's how you know you're moving into moderate. Because now, we're not just getting lost, we're wandering. We're wandering off. We're disoriented regarding the time of the day and even the season. We're wearing shorts and there's snow outside and we're taking the trash out in shorts. 10 degrees out. That's why you get those patients like that. They're completely out of the season even. There's no orientation to the season, much less the day. They now can't tell you their phone number. and they are taking part in this. What in the world is this? What is confabulation? Make it up shit. You just gonna make it up, huh? You just gonna make it up. So fill in the blanks with stories. And I mean, there'd be some fabulous stories. You're like, Papa, what you say? I don't think so now. Okay. So now we're definitely wandering, getting lost, losing address, don't know the number. I think we really were scared when Papa came home, and Papa has a big wad of money in the broccoli clip, like the mafia, you know, the broccoli rubber band, right? Mm-hmm. He always has big wad of money, huge money. And we were like, he cannot keep taking money out of here. One day he's coming back and he's not gonna have all that money. And he did. He never knew it. He has no idea where it went, where he spent it on, or if he even spent it. And then it's poor, very poor judgment. He decided to buy a navigator. Just out of the blue. I want a new truck, he says. And because he's the he-man, Mama says, you can't buy a new truck. You don't want a new truck. You got the other truck. You got a bunch of trucks. You don't want a new truck. And I said, I want a new truck, and Dad, I'm getting one. And that's what he did. Sit in the garage. She won't let it go. For 5 years, 7 now, she will not let that truck go. Just sitting there to remind her again. So big ass navigator, drove it twice. Paid cash, whatever. Okay, so that is the moderate, right? Now let's do severe. I think you know where we're going. We are incontinent. We have muscle rigidity. We are unable to do ADLs. No talking, no walking. Fetal position. Pneumonia and UTIs. Dysphagia. Put a star by that one. Dysphagia. I would think that we all know what to do with mild, and we probably know a good bit of what to do with moderate. I think your biggest issue is what to do with severe. Severe aromatherapy, music. Who's seen the video where the lady comes in? I think it was a social worker, I can't remember who it was, might have been the nurse. Comes in every single day and sings a beautiful song and plays it.
Yeah,
Oh my God. So this nurse or social worker is singing the song in this stage, the severe late stage of Alzheimer's, to this patient who's pretty stiff, barely sitting up in the chair, kind of out of it, has no concept of anything, so we think, but she keeps singing the same song. And about, I don't know how many weeks later, the patient begins singing the song back to her. Just know they hear you. They hear you, don't write them off. Okay? So this patient needs music and talking and loving and touching and aromatherapy and thirsty blankets and towels and soft teddy bears, and it's all about what? Senses. The 5 senses. Smell, touch, sight, hearing, smells, taste. Okay? So remember, wake up the 5 senses. Okay? That's what you're doing in this stage. And you are protecting them because abuse and rape and everything else has happened to these patients. Everything else has happened to these patients. Especially molestation, guys. Do not underestimate the ability of the staff at your facility to rape patients that are out of it. Happens more often than you know. In fact, you may or may not remember that the young man who was in a coma for 14 years and came out, literally just came out. He wrote a book about it, and his book included the fact that there was never a time when he spent a day in any institution, and I think he had about 10 different institutions he stayed in, that the roommate next to him was not raped or sexually molested in some way. And I think what's even sadder is what he didn't write, which said it probably happened to her, because he was the one in the coma. But he could tell these things were going on, because again, in a coma you can hear everything. And remember what God does. When one sense is faded, the other one is sharper. So your ears are sharper. Okay? Okay. Now, so that is your Alzheimer's. And the medication for your Alzheimer's is the last page or so. And then, of course, you have pain meds on the back. Now, on the page where you have Aricept, I want you just to write a couple things real quick, and then we'll do a little spiel on pressure ulcers, but we're doing pretty fabulous with that. Okay, for your page that has Aricept on it, let's give you the other medications, and you're just going to write them down. Obviously, they're in your medication packet. Exelon is a transdermal. Ribostigmine is the actual generic, just like Aricept is donepezil. So just write that down. Remember to remove the previous patches, right? This is changed every day, by the way. So, you know, you're putting on a new patch every single day. If your patient is drooling, they're overdosed, which is what that patient was doing with their 5 patches on. So I call it the 4 Ds, which equals dizzy. Patient will be dizzy, they'll be drooling, they'll be drowsy, which she said her patient was very loopy, and they'll be diaphoretic when they're overdosed, which means they have all those patches on that some asshole didn't take off. 4 Ds of overdose with Exelon patches. The other medication that we like to use, Razidine is the brand name, and galantamine is the generic. The problem with this medication is weight loss. Now, Aricept, Exelon, Razidine, mild to moderate Alzheimer's. Remember why we give it. It does not prevent Alzheimer's. It doesn't treat Alzheimer's. What it does is it makes the patient able to do their activity of daily living better. It gives them the ability to do the activities of daily living better. Once the patient is in moderate to severe Alzheimer's, and I always say remember it like this. In moderate to severe Alzheimer's, they don't even know their name, right? Namenda. Namenda, of course, is the brand name. Memantine, which I've seen a million times, is the actual generic, Memantine. This is moderate to severe Alzheimer's. All of these medications, you have hepatotoxicity as a risk. Hepatotoxicity, so watch the liver. Now, let me give you 2 more things on plain old-fashioned Aricept, because it's so popular. Never abruptly stop it, or you're going to get rapid deterioration. Never abruptly stop Aricept, or you're going to get rapid deterioration and diarrhea. So watch for diarrhea in all of these patients, right? Because almost everybody's on Aricept. Also, take it in the evening. Okay, cool. Now, I I'm not going through the burns completely, we don't do burns today, right? But in the burns packet is your pressure ulcers. And I'm gonna tell you, I want you to find the page that shows stages or something. Let me find it. Find where I'm going. I put the negative wound back in there. I put all the pictures of that in there. I put your stage 4, 1, 2, 3, I put all that. I put pressure injury prevention. I put all kind of crazy stuff in there, okay? So what I want you to do is find where it says news and analysis. This is the most important page in the packet for what you needed to do. So it looks like that. Always look up and see if you're matching. News and analysis, okay. All right, now, so news and analysis, 1, 2, 3, 4, okay? Now, everything I wrote is already in here. What I need you to do is highlight what I wrote that is in here, okay? Oh, here, I thought you had it over there. You sure? Okay. Oh, there you go, I forgot about that. Okay, so highlight these, because the words are right in there. Do you see the first one? Does it say unblanchable in that sentence somewhere? Boom, must be important, huh? Redness and unblanchable. Can you find, and if you don't see the words that I wrote, add my words, right? But see if you can. Stage 2 is like, the skin is broken. What I'm trying to tell you is, with stage 2, the skin has to be broken for you to say it's out of stage 1. So if the skin is broken, it's not in stage 1 anymore. Skin is broken, and maybe it looks like an ulcer to you. Maybe it's already blisters. So this is all stage 2 for ulcer, blisters, and skin is broken. The biggest thing in stage 3 is now you've gone down to injure the subcutaneous tissue. It may even be like a crater, very deep, and there may be tunneling. Stage 4, exposed bone, muscles, tendons. You want to remember that they may not say bones, they may say muscles and tendons. That's stage 4. What is that patient at risk for with bone exposed? Osteomyelitis. Stage 3 and 4 might need a negative wound vac. Stage 3, pressure injury, and stage 4 may need a negative wound vac. They usually need chemical debridement. Chemical debridement with an enzyme or so. All of these patients need high protein, high vitamin C, and zinc. High protein, high vitamin C, and zinc. Unstageable, the wound is covered with slough. Use those, find those words. Slough, debris, eschar, necrotic tissue. I tried to color it what it would look like. So slough would maybe yellowish, blackish, weirdest pussy color. Debris is just gunk and crap in it. Exfoliation is garbage. Eschar is, of course, eschar, necrotic tissue is dead and it's black. Remember what we talked about, black is dead. Black tissue with the sore in the wound is dead tissue. The depth of the wound cannot be determined. That's what unstageable means, and yes, you have to know that. The depth of the wound is unable to be determined. Okay? Okay, babies. So I'm going to